Okay, so we covered the anatomy of the heart last week, but we're going to do a brisk review before we move on to some more of the physiology of the heart and some more of the terminology. So recall that we can divide the heart into superior and inferior between atria and ventricles, but we can also divide it between the right side and the left side of the heart, with the right side of the heart pumping to the pulmonary circuit and the left side of the heart pumping to the systemic circuit. Our best definition for arteries and veins now is that arteries carry blood away from the heart and veins carry blood back to the heart. We no longer use oxygenated and deoxygenated because the pulmonary circuit has those reversed. Blood flow through the heart is unidirectional. If it's not, you've got a problem. Blood pressure is about the force of blood pushing against the walls of blood vessels, and that's going to correlate with a lot of things that we'll start talking about next week in terms of blood volume, blood pressure, diameter of the blood vessels. There's going to be more about that next week, though. The heart is located within the mediastinum, or mediastinum, depending on who you ask. That mediastinum includes those great vessels superior to the heart, the thymus gland, some other stuff there too. The pericardial cavity just includes the heart muscle itself. The layers of the pericardium, from superficial to deep, you have a fibrous pericardium. You have your serous pericardium divided into parietal and visceral, and then the visceral layer is synonymous with what layer of the heart wall? The epicardium. Epicardium is synonymous with the visceral layer of the serous pericardium. Deep to the epicardium, you have the myocardium. That's going to be the thick portion that's primarily composed of cardiac muscle cells, cardiomyocytes. And then the internal surface has a layer of endocardium. And again, those terms are significant because you can have endocarditis, you can have different layers be infected or inflamed and have different medical terms for each of those. Again, epicardium, there can be a variable layer of adipose tissue associated with that epicardium, superficial to the epicardium in some cases. We will see quite a bit of fat around our sheep hearts. Myocardium and endocardium, there's some connective tissue layers between these layers as well, which again, if somebody has a connective tissue problem or disorder, that's going to have clinical significance. Great vessels, superior and inferior vena cavae. Superior drains from the head and arms, inferior from the rest of the body, but they both carry deoxygenated blood to what chamber? The right atrium, good. The aorta is your next great vessel. It carries oxygenated blood from the what chamber? Left ventricle. This is the pulmonary trunk to the pulmonary arteries. And again, arteries, it's in blue because it carries deoxygenated, but it's an artery because how do we define an artery? Carries blood away, good. This is carrying blood from which chamber? The right ventricle, there we go. And the pulmonary veins, which are here in red because they're carrying blood to the heart, they're still veins, are carrying oxygenated blood from the lungs to the left atrium. Great. This vessel is the same as this vessel there, continuous. That aorta is deflected a bit to the left, laterally and posterior to the heart. Here's a posterior view. You can see all of the same great vessels, the superior and inferior vena cavae, the aortic arch, the pulmonary artery, the pulmonary veins. And then we have the addition of this guy, the coronary sinus. What chamber does the coronary sinus drain to? Right atrium. All deoxygenated blood is going back to the right atrium. Internally, you have your two atria. And this is what I was talking about, Chris, with maybe just that view showing a different volume of blood, where it's a little bit rotated. The volume in this atrium should be approximately the same as the volume in this atrium. Yeah. I say approximately. some features inside of the right atrium. You're going to have an opening for the coronary sinus, openings for each of the vena cavae, and a fossa ovalis. Does anybody remember what that was a remnant of by any chance? The hole in the heart. So before you were born, fetal circulation, you had a foramen ovale there instead. Then you have this valve. What was this valve called? Right AV valve, or the tricuspid valve. So it has three major cusps. These cords right here, these tendinous structures, are known as what? Chordae tendineae. And the muscles that anchor them to the wall are known as papillary muscles. And you have these rugosities, these sort of foldy folds inside of your ventricles. You have some in your atria as well. What are those known as? No, Purkinje fibers. See where you're coming from. Correct. Trabeculae carnae is the name of the folds, and you'll be able to see those quite clearly on the sheet parts as well. Then on the left side, you have the left atrium. There should be 4 openings for each of the pulmonary veins. And then we have this valve, which is known as the left AV, or the mitral, or the bicuspid. Absolutely. There's 2 cusps. More chordae tendineae, more papillary muscles, more trabeculae carnae in here. So I could ask you for those features on either side. The divisions between the atria and the ventricles, this divider is gonna be known as what? The atrial septum, and this divider is known as the ventricular septum. The walls to the ventricle on the left are 3 times thicker than the walls on the right. Why? Because it has to pump to the body, whereas this just has to pump to the lungs. Okay, good. What else? We're good there. Oh yeah, I forgot the semilunar valves. This one's going to be the pulmonary semilunar valve. You could also call it pulmonic. If you do say semilunar, please write pulmonary semilunar valve for completeness. This is not one where you've got a nice acronym for it. And otherwise you can write pulmonic. That is technically acceptable. And then this one back here that's going to the aorta is the aortic semilunar valve. Okay. What is the role of the fibrous skeleton? Electrical insulation. It's also structural and support, but the one we're going to focus on is electrical insulation, so that the atria can contract independently of the ventricles, and we're going to only have that controlled pathway electrically to cause that heart contraction. We really, really, really need that coordination between the atria and the ventricles. We really need them to pump 1 and then 2. Are these the same concept on this picture? Nope, these are different concepts. This is about the fibrous skeleton and how those valves are partially derived from the fibrous skeleton. And this is about the direction of muscle contraction, with atria contracting inward from the lateral aspect, and the ventricles squeezing from the bottom up like a tube of toothpaste. Yes?
Is that basically the conducting system of the heart, like fibrous skeleton?
So the fibrous skeleton is what prevents the electrical impulses from traveling between the atria and the ventricles. That it is related to our conducting system in the sense that there will be very specific locations where we can bypass the fibrous skeleton. We're going to have a delay at that AV node so that the atria contract and then the ventricles contract. And if it weren't for that fibrous skeleton, we wouldn't be able to keep that electrically separated.
Is that because of the pathway? The internodal pathway?
Internodal pathway communicating between the SA and the AV node.
To keep them from doing it at the same time?
So the pathway is how the SA gets to the AV, and then it's delayed at the AV, as I understand it. Yep. Again, this is the same concept as this right here, just the direction of muscle contraction. So we covered all of this. I feel pretty good about it. This is a superior and right view of the right atrium, looking down at that right AV valve and seeing the nice fossa ovalis there. This is an anterior view showing that, what's the word, conus arteriosus, that smooth region that leads to the pulmonary semilunar valve. Conus arteriosus. I think we're pretty good on all of this anatomy. I think we covered this. Okay, coronary circulation. Right and left coronary arteries. Give me a couple of names for this guy right here. Left anterior descending. If you're a cardiologist, you're probably going to use LAD. And then if you're not, if you're an anatomist and you just like things to be really descriptive and standardized, you say anterior interventricular artery, which means this one on the posterior surface, since this is a 3D image, posterior interventricular artery. And this one right on the margin of the heart on the right side, right marginal artery, absolutely. So again, the left coronary artery gives rise to our LAD. The right coronary artery gives rise to the posterior interventricular and the marginal as well. Those also reside in the coronary sulci. So anterior coronary sulcus, or interventricular sulcus, posterior interventricular sulcus. Now there's the coronary sinus again. Instead of anterior, posterior, interventricular, this and that, what's our naming convention here? Great, middle, and small. This one on the front is the great, this one on the back is the middle, and this one on the margin is small. So on your lab practical, if I'm pointing to an image like, sorry, I have to zoom through a bunch of slides here real quick. If I'm pointing to an image like this, and let's say the arrow's right there, it's not always obvious if I'm pointing at the artery or the vein, so I will write red or blue. Same for something like this, I might write red or blue, but you still have to remember that blue's not always a vein, sometimes it's an artery, so you still have to keep those straight. But I will write red or blue for you and make sure that you can tell exactly which one I'm pointing at, even if the arrow's just kind of shoved in there. And again, those drain to the coronary sinus, which drains right there to the right atrium. Okay, systemic veins, superior inferior vena cava, right atrium, right AV valve, right ventricle, pulmonary semilunar valve, pulmonary trunk to pulmonary arteries, gas exchange in the lungs, pulmonary veins, left atrium, left AV valve, left ventricle, aortic semilunar valve, aorta, systemic arteries, gas and nutrient exchange in the peripheral tissues, that is cellular respiration. And back to systemic veins and the superior and inferior vena cava. Okay, histologically, you have to remember that cardiomyocytes are branched, usually uninucleated, occasionally a couple of nuclei in there. And then they have these cool features called intercalated discs with gap junctions. And gap junctions allow for what? Not the electrical insulation. It allows for ions to pass through. Ions are electrical. Ions are positive or negative atoms, right? Which means that that electrical impulse will be carried through every single intercalated disc between every single connected branched cell. So everything along your heart will be connected except where insulated by that fibrous skeleton. Otherwise, contraction happens in the cardiomyocyte very similarly to how it happens in a skeletal muscle. You're going to have several ions involved. It's still going to be related to neurotransmitter release, but except that you do have that pacemaker and autorhythmicity of the heart from that SA node. It will be influenced by your autonomic system, but not initiated by your autonomic nervous system is the best way to say that. It is going to rely on sodium to depolarize the membrane. It's going to rely on calcium to move that troponin away from tropomyosin. Tropomyosin away from the actin. Yes, actin. And you still have sarcomeres that are going to contract. Your cardiac muscles, thankfully, have a long absolute refractory period in which they cannot contract again, which is really, really important. If they could contract more frequently or prematurely, that's going to lead to an arrhythmia, and that can potentially kill you. So we don't like that. Okay, we start at the SA node. Then we go via the internodal pathway to the AV node. Then from the AV node, that's where we get that slight delay so that the atria contract and then the ventricles contract. Then the AV propagates action potentials along the bundle of His, or atrioventricular bundle, if you want to be new school. That bundle then branches, and at the apex of the heart, they split and return back up the sides of the heart wall, and those are Purkinje fibers. So the mnemonic that I created for this was save his bundles Purkinje. Now again, do not forget that this is the division between bundle branch and the Purkinje fibers. The apex of the heart right here is the dividing line. So if the arrow's here, that's a Purkinje fiber. If the arrow's here, that's a bundle branch. Does that make sense to everyone? Okay. And this green portion does show you how that action potential is propagating. The SA initiating the action potential throughout the atria, and the AV sending that electrical signal down so that it contracts from the bottom up. The SA node is the pacemaker. Without autonomic regulation, what would your heart rate be? 100 beats per minute. So the SA node fires without input from the parasympathetic nervous system at 100 beats per minute. And then what's our main cranial nerve that is going to control the parasympathetic division here? Vagus! Yeah, it's always vagus. So vagus is going to innervate both the SA and AV nodes. It's going to have two different branches, one for each of those. And that's going to slow it down for your sort of typical heart rate. What's a normal heart rate? 60 to 80. 100's getting into tachycardia, but yeah, I mean, honestly, my typical like standing around heart rate is 90 beats per minute, which is a bit high, but that's just how it is. Let's see, SA node, AV bundle. Bundle of His is the old school, left and right bundle branches for Purkinje fibers. At this point last class, we watched our Living Arrhythmias video, and that's always really valuable for utilizing some of these vocabulary words. For example, we saw a bundle branch block is one of the things that we saw. That's the funny guy doing the, what's that? Yeah, we can absolutely watch it again. We'll get through some more stuff and then we'll watch it again probably when we're done with the lecture. All of these action potentials propagating across the heart from one side to the other, to the superior right, to the inferior left, and then back up the Purkinje fibers, that is summated into our typical ECG pattern. So you guys got the coloring page last week where it showed you action potentials fire here, action potentials fire there, action potentials fire there, action potentials fire there, and then when we overlay all of those lines together, this is the sort of sum of all of those peaks all at the same time. Now we can get individual readings from different electrodes. Today we're just going to do a 4-lead ECG, like a really, really simple one. And again, we're not going to diagnose anybody from it because we are students, or you are students, and I'm not trained in reading ECGs, so that's not going to happen. If you don't have a P wave, that's okay. You don't have a P wave. It's not that your atria aren't contracting. It's just not reading very well, and that is fine. There is some math to be done in this course. You will not do any of the math. It is interesting to know that for every bold blue line, you are looking at the 1/5 of a second. So if you have a peak, the same peak hitting every 5 bold blue lines, that's a beat for every, what time frame? Second. So every 5 of these is 1 second. Which means if you're seeing this sinus rhythm, what's their heart rate? 60 beats per minute. So this is a really good, healthy, perfect heart rate right here. Question? Nope. Okay. So P wave was what? Atrial depolarization. QRS was what? Ventricular depolarization, and the T wave was ventricular repolarization. Was there, hypothetically speaking, a wave for atrial repolarization? Yes. Why can't we see it? Because this is so massive. Absolutely. And again, depolarization is going to be connected to the idea of contraction. It's going to be a very, very minute delay between the electrical impulse and the physical contraction of that region. So after that P wave is detected, then atrial contraction will begin. After that QRS is detected, then your ventricular contraction will begin, and as that T wave is detected, ventricular repolarization will begin. Yes, Chris?
So I just have a problem with like remembering what polarization and polarization is. Is it fair enough to look at it as polarization is like taking away two elements? And polarization is putting those back to back.
Sure, if it works for you to make that connection, to compare it to contraction and relaxation. I would focus on how it impacts contraction and relaxation if you can't make depolarization and repolarization work. But again, think about, here's our neuron action potential. This is -70, this is +30, zeros right about here, right? And this is in millivolts. So this is about polarity of electrical inputs, right? So this is more polar, and this is less polar. Yeah, does that make more sense? Okay. Personally, I don't mind comparing magnets to electricity. Physicists get a little pissy about saying magnets and electrical, like magnet positive, negative, and electrical positive, negative are the same. They're quite different. Yes?
Can you kind of tie in how the P, or like the entire ECG goes into like the SA, AV?
Absolutely, yeah, and that's one of the things you're going to do today. So the SA node fires, and those are the electrical impulses that are detected with a P wave.
Okay.
Yep. That AV node fires and sends that along the bundle of His and the bundle branches and Purkinje fibers. That whole thing is the QRS complex.
Okay.
And when that signal has ceased, and you're in that refractory period, and we repolarize, we reset everything, that's going to be the T wave.
Okay.
Yeah.
And then it starts over
And then it starts over with P. So it's PQRST, PQRST. Yeah. In rare instances, you may have a U wave. That's this guy right here. This is something that'll be seen with very, very slow heart rates, or typically in the elderly, as I understand it. Sound right?
Yep.
Yep.
What is happening?
What's happening there, I'm not entirely sure exactly what's happening there. More electrical activity. Do you know anything about U waves beyond that?
The U wave is just kind of, you have to talk to a cardiologist.
Yeah.
If it's there, we permit it, but it's, even the cardiologist knows how to do it.
Yeah.
Yeah.
I work at a cardiology office. I've never heard of UA aside from
Yeah. It's not a huge deal just to know that there's another letter of the alphabet in there, at least for the now, unless you go into cardiology. Yeah. Good question for Karen Riley, too. All right, you have a cardiac plexus. Thankfully for AMP2, all of these plexuses are pretty well named for what they're going to contribute to. And again, you do have the vagus nerve, cranial nerve 10, innervating both the SA and the AV. There's that green line right there. There's the SA, there's the AV. And then you have sympathetic innervation. It actually activates beta-1 adrenergic receptors of the heart muscle. I'm putting the full word, beta-1 adrenergic receptors. That's important for you really long term. That's important for pharmacology. You're going to have beta-1, beta-2, beta-3, alpha-1, alpha-2, adrenergic receptors, and you're going to have things like beta blockers and beta-1 blockers, beta-2 blockers, and they're going to act on different areas. So if you can act on beta-1 receptors, you can block those receptors. then you can decrease that effect of the sympathetic nervous system. So what would the sympathetic nervous system do to heart rate and contractility in general? Increase heart rate, increase contractility. So you will end up seeing some pharmacology around these terms. If you can shove them into your brain before you take pharmacology, awesome. That'll make your life easier. Okay, vagus nerve releases acetylcholine, and again, it's parasympathetic, so it's there to decrease the heart rate. Tachycardia defined as more than 100 beats per minute. Bradycardia defined as slower than 60 beats per minute. But who's going to have just a normal heart rate of 40 beats per minute, just like a healthy person? Yeah, athletes, endurance athletes especially. So marathon runners, absolutely. All right, one more set of vocab. Well, there's a little bit more vocab, but there's another set of vocab words to shove under the concept of contraction and relaxation. We're not going to keep using it contracts and it relaxes. We're going to use systole and diastole. You've probably taken blood pressure or are familiar with the process of taking blood pressure, and you know that you take, I believe it's systolic over diastolic. Yep, systolic over diastolic pressure. If it's not specified, if it's the atria contracting or the ventricles contracting, we assume they're talking about ventricles. So that systolic is about ventricular systole, that diastolic blood pressure is about ventricular diastole. So your default mode is assuming systole or diastole for ventricles. Otherwise, they'll specify and say atrial systole. There's such a thing as atrial systole. That is when the atria contract. Or atrial diastole when the atria relax. Ventricular systole when the ventricles contract. Ventricular diastole when the ventricles relax. Are we comfortable with the default mode is ventricles concept? Okay, you are, but you already work with it. Is everybody else comfortable with the default mode is ventricles? Okay. So for your worksheet today, it's pretty involved, it's pretty complex, because I'm going to make you shove all of this information onto one worksheet in a sort of columns pattern based on this cardiac cycle right here. So on your worksheet, you're first going to talk about the cardiac cycle in general. You'll talk a little bit about which valves are open and which valves are closed. Then I'll have you draw out the ECG pattern, sort of in a way that connects it to those columns. I'll have you talk about the conducting system at the same time that you draw out the ECG pattern. And then we're going to go to, where is it? This. This is about pressures in different chambers throughout the cardiac cycle. Here's our PQRST down here, and that's how that's going to connect to the pressures. And as you talk about the pressures, you also have to talk about the valves, and you'll see why when we get to it. And that's all going in it together. So it's going to go in, here's part 1 of the cardiac cycle, here's part 2, part 3, part 4, part 5. What's happening with the valves? What's happening electrically? What's happening on the ECG? What's happening with pressures? Straight down that column for that whole thing. Okay, does that make sense? So I'll do this here, and then I'm going to pause it because we're going to do it like 5 more times, but I'm assuming it's recording, so you can replay it. So atrial systole begins. When atrial systole begins, that's atrial contraction. At this stage, those atria should be relatively filled with blood. They start contracting by definition. As they're contracting, those AV valves, both right and left, should be open. And that should be draining and then pumping into the ventricles. That blood should be going down here. Then atrial systole ends and atrial diastole begins. And then you start ventricular systole. There is actually a phase that's not being addressed here called isovolumetric contraction. Just a tiny, tiny fraction of a second where both atria and ventricles are depolarized. It's very, very brief. I don't really care about it that much, but I think your exam might have something related to isovolumetric relaxation and isovolumetric contraction phases. So that would be in between these two phases. Isovolumetric contraction is a very, very brief moment where everything is a little bit contracted, and specifically all of these valves are going to be closed. So the thing that's going to close the AV valves is the contraction, the systole of the ventricles. What's going to happen is there's blood in the ventricles, there's pressure being put on that blood, that pressure in the ventricles increases, and that backwards force against the AV valves is what shuts it. It goes like this. Ventricular systole continues, and then the pressure that builds of that blood is actually going to be what opens the semilunar valves. They're facing this way. That blood is being squeezed like a tube of toothpaste, so they open up in response to that increasing pressure in the ventricles. So far, so good? Ventricular diastole begins, and at this phase, there's no valves on the vena cava or pulmonary veins, so any kind of respiratory pump, we'll talk about the respiratory pump next week, it means that your atria are already passively filling when they're relaxed. In early ventricular diastole, the pressure is decreasing in the ventricles. And because of that, there's blood in the aorta, there's blood in the pulmonary trunk. Because it's decreasing, think of like releasing a bottle and having a little bit of suction. That blood wants to follow gravity and go back into the ventricles. But the valves are there, and in response to that pressure of the blood in the aorta, which is the one we're going to track, that's going to close the semilunar valves. So for this very brief moment, you're going to have all valves be closed again. Then you're going to go into late ventricular diastole. Your semilunar valves are closed, but your AV valves passively open. That's a passive act. They don't need to be pushed. They prefer to be open. If there's no pressure acting on them, they'll be open. And then we return to the beginning of the cardiac cycle again. All right, a little bit more vocab. To understand end diastolic volume and end systolic volume, again, if we don't specify, we're talking about the ventricles. So I want you to imagine the ventricle as like a water bottle. And I want you to think of ventricular contraction as like squeezing it. It's got to be one of those cheap, like plastic water bottles. So, and what's diastole again? Contraction or relaxation? Relaxation, good. So that's going to be when the ventricles are entirely relaxed. Are they going to be filled or empty at the end of that relaxation phase? Filled, right before they contract. So after they're completely filled, that's your end diastolic volume. That's the maximum that they can hold while they're relaxed, right? Then systolic is what? Systole is what? Contraction. So after you've squeezed that water bottle as hard as you physically can, did you effectively get all of the water out of it? Or is there some left? There's some left. It's a pretty efficient mechanism, your heart while contracting, but it's not perfect. So after that contraction, there's still some volume left in that ventricle, and that's your end systolic volume. I mentioned this isovolumetric contraction, isovolumetric relaxation is early ventricular diastole. When the ventricles are relaxed and the atria are relaxed and filling, it's a very, very brief moment. You'll see it right about here. So right about here would be isovolumetric relaxation. I'm going to jazz hands that one. On our pressures chart, we're going to see this very important vocab word, the dichrotic notch. And I've always emphasized the dichrotic notch. So what it means is, we mentioned before those semilunar valves close, we've got relaxation in the ventricles, and that blood wants to flow back into the ventricles, right? The reason it can't is the semilunar valves are there, and the pressure of the backflow on the blood onto the semilunar valves is what physically closes them. So imagine like a ton of water just falling backwards on this valve. That causes a brief increase in pressure within the aorta that we can detect. And we're going to detect that on our pressures chart that's coming up. And that's going to be called a dicrotic notch. And I'll point it out when we get there too.
And that's just the pressure on the BIOL224?
Exactly. There are some really good videos on YouTube for like a 3D animation of what this heart pumping actually looks like. Blood filling the atria, blood filling the ventricles pumping it out, refilling in the atria, and it's that cycle going again and again. I think these two-dimensional pictures just really can't compete with it. This is the idea though. Wee, wee, wee. So, okay, I will watch some of those videos later, and if I find a really good one, we'll link to it. So, I want you to prove to yourself really quick that contracting muscles don't actually make a sound. There's a reason I'm going to make you do this. Listen to your bicep. Does it make a sound as it contracts? No. So what are heart sounds then? Valves closing. Yep. So I was kind of trying to do it as I was demonstrating. Here's your AV valves closing, and here's your semilunar valves closing, and trying to make like a little smacking sound as I did that. That's because those are the heart sounds. Your AV valves close first in that cycle that we talked about. That is going to be your LUP. That's heart sound 1, S1. The semilunar valves closing, that's the second sound. That's the DUP. That's SL2, or S2. These are the locations where it is best to listen to each valve specifically. I don't really have anything to add to that. Okay, pressures chart. If you were paying attention during cardiac cycle, this should make a certain amount of sense. And on your exam, it's going to be in black and white, but I'll tell you what the colors are as I walk through this anyway. This blue line is going to trace the pressure in your ventricles, and the rest of it's like gray. So this gray line down here is the pressure in your atria, and this other gray line, thanks for making it all gray, dudes, is in your aorta. So these are the places where we are tracking pressures. This is also tracking volume down here, not pressure. We can, for now, safely ignore this. Long term, you are going to see this chart again. You're going to see this chart in med-surg, I believe. You're going to see this medically, clinically. So you're just seeing it for the first time here. This never goes away. Okay, so as we go through that cardiac cycle, P represents what? Depolarization of the atria. So atrial systole begins, and this gray line down here is showing you pressure in the atria. So as the atria contracts, just literally the pressure on the blood increases. So you have this little bump right here for the increase in atrial pressure. And then you have QRS, which represents what? Ventricular depolarization. So right after the ventricles depolarize, you'll start your ventricular systole. And right here is the location where those AV valves closed, and that's going to allow for that great increase in pressure in the ventricles along this blue line. So here's the increasing pressure in the ventricles. Here's the location where the AV valves closed. The pressure increases to the point where the pressure in the ventricles overcomes the resistance in the aorta, and the aortic semilunar valve opens right at this point on this chart. That pressure continues to increase, and then ventricular diastole begins, and you start to see repolarization and a decrease in pressure on the blood in the ventricles. As that pressure decreases in the ventricles, now you have an attempted backflow of blood from the aorta, and now we're tracking the pressure within the aorta along this gray line, and see this notch right there? There's your dicrotic notch where the aortic semilunar valve closes. That's that pressure backflow of blood in the aorta against that semilunar valve going. So this is going to be LUP. This is going to be DUP. Yep.
Wait. What was love and what was done?
LUP. DUP. Yep. Pressure continues to decrease, and once that pressure is really gone from those ventricles, those AV valves open again. All right, what did this peak in pressure represent? Atrial depolarization. What did this blue peak in pressure represent? Ventricular depolarization. What did this decreasing pressure represent? Ventricular repolarization. What did the dicrotic notch represent? Aortic valve closing. Good. Increased pressure in the aorta right there. Where did the AV valve close? Over there, yes. That is correct. AV valve closed here. Aortic valve opened here. Aortic valve closed here. AV valve opened here. So that fits really well with our chairs model too. It's a good time to revisit those chairs. Yep.
The love with the AV valves, right?
LUP.
The dub was okay.
Dub.
Just to make sure I got that right.
Yep. S1, S2. Good. Yep. And if you want to do this line right now, this is not something I'm going to test you on, but if you want to do this line, it just makes sense that the volume of blood in your ventricles decreases as you eject that blood out of your ventricles. That's all that that's saying. So ventricle volume goes down as that blood is ejected. Yeah, Debbie?
I'm sorry, I'm so confused. I thought you said dub was the semilunar valves.
This is the aortic semilunar valve.
Oh, okay.
Yep. That's okay. All right, are we excited about this chart yet? So many charts. A little bit more cleanup. We're almost there. 11 slides to go. Do you guys want to take a break right now? Just pause it. All right. We can do this math style or we can do this not math style. You need to know the concept of cardiac output. And really, it's pretty intuitive. Your heart rate times the amount of blood that you eject with each stroke, your stroke volume, is your cardiac output. So what this means is if you've got 60 beats per minute and you are ejecting about 70 milliliters per beat, then you're going to end up with a unit in milliliters or liters per minute. So all that's saying is we can measure how much blood in a minute your heart is successfully ejecting into your body. So that's going to be an important clinical value for you to monitor cardiac output. When we talk about patho, we're going to say this is going to alter cardiac output, or this is going to compensate for cardiac output. So the units are important, the terminology is important, the math is helpful to understand it, I think. So cardiac output is going to be partially based on stroke volume. Stroke volume is end diastolic volume minus end systolic volume. So we talked about that water bottle being symbolic for the ventricle. We filled it with water, and at the end of diastole, it was completely full. And then at the end of systole, we squeezed out as much as we could, but there was still some left. So the stuff that was ejected out, that is what we can calculate as your stroke volume. And the reason we can calculate it this way, one imaging technique that can help you get to these numbers, I'm sure it's not the only one, but I know you can do this with an echocardiogram, is you can get some of these values. We also have to talk about preload and afterload and contractility. So preload is how much your cardiac muscle cells, your cardiomyocytes, are stretched out when they're filled. So maybe like a balloon or something kind of elastic. So think of an elastic band. You stretch it, you stretch it, you stretch it. If you stretch it as far as it can go, it's going to rebound more forcefully than if you only stretched it a little bit. Do we all agree with that concept? So it is possible to overstretch that rubber band. That's a different law. The law today is that the more you stretch the rubber band, the harder the recoil. So the more you fill that heart with blood, the more blood volume you have in that heart before it contracts, the more forcefully it's going to contract. Yes?
So with my daughter, she has an enlarged left ventricle. Is that like the blood flow is causing the left ventricle to be.
It depends on what that is. There's such a thing as a dilated cardiomyopathy, which may not be the same thing as what she has.
No, it's because of the ventricle septal defect.
Okay.
And the blood going, there's too much blood in the left.
Gotcha. So yeah, probably just a dilation. I don't know if there's a weakness to it because of that.
Yeah.
It is possible to overstretch it and it becomes weaker.
Yeah, that's, yeah.
Okay. But this is not that situation. Frank-Starling law just means more stretch equals more contraction. Yes?
So how does that tie into if you have some sort of volume problem, say traumatic? Doesn't the heart try and beat harder?
Yes.
To pump more?
Yeah, if you're experiencing hypovolemia,
Right.
your heart is going to try to compensate for the lack of cardiac output by increasing contractility and heart rate.
So it can be inverse. It can be an inverse relationship.
Between
This
what?
seems like it's a pretty okay, the more blood you have, the harder it's going to contract. But what if you have less blood? It's also going to contract.
Yeah, it kind of goes both ways.
Okay.
It's like your heart is like, well, I don't know what's going on. I'm going to beat faster.
Okay.
That's actually accurate. Yeah. That's great. Yeah, I can't think of that many disease states where it beats slower necessarily, aside from just weakness.
Yeah.
All right, so preload is the degree of stretch. Preload is how much we put in there exerting force on the walls of the heart. A big important factor for that stretch, for that preload, is venous return, the amount of blood returning to the heart. And again, in the case of hypovolemia, like a stab wound, there's not going to be as much venous return to the heart. I don't think I have anything to add to that one. Contractility. Sympathetic stimulation and certain drugs are going to increase contractility. So we can use drugs like digitalis, thyroxine, glucagon, epinephrine. Or if somebody has high extracellular calcium, those are going to increase contractility. Hold on just a second. I would cross out high extracellular calcium on this one, and we'll tell you why in a second. There's a slide coming up that's a little bit wrong, and there's a reason it's wrong. It's not, I'll get to it when I get to it. Too much potassium, acidosis, those would decrease contractility. Now, preload was how much we filled that water bottle. Afterload is taking in consideration the fact that when we squeeze the water bottle, we're not actually squeezing into the air. That ventricle is squeezing into blood vessels, and the blood vessels have their own resistance. You went from air to like a garden hose, and then you go from garden hoses to straws, right? You're going to decreasing sizes, decreasing diameters. So there's pressure in that system already. So it's the pressure that the ventricles have to overcome in order to eject that fluid. If you have systemic high blood pressure, hypertension, that means there's more afterload. That means that all of those hoses and pipes, all of those blood vessels are going to be more constricted or have less space for that blood to eject to, and that means they're going to have more resistance, which means you're going to have more afterload. It's going to be more of a struggle for your heart to eject that fluid. What happens when a muscle has to work harder to eject? It gets bigger, hypertrophy, absolutely. All right, Bainbridge reflex, stretch on the atrial walls also increases heart rate. Everything's just basically going to increase heart rate, except for the mammalian dive reflex. And I've tried to duplicate this in class. It has not been successful, basically because we ended up almost waterboarding people. The idea here is that if you're in cold water, if your face is completely submerged in cold water, you have a weird reflex where your heart rate slows down. And we're not entirely sure why. It may be related to sort of the semi-aquatic history where we're preserving oxygen and slowing things down a little bit. That's about all we have. It's a cool reflex. Technically, if we managed to submerge somebody's face in cold water, we could see their heart rate decline. Did not work in a classroom setting, just so you know. I think all we tried were like paper towels on the face, and we like tried to have, you know, holes for breathing and things like that. It still ended up looking kind of fishy, and I think the guy we did it to was military too, so we're like, you know what, I'm sorry, let's stop this. Let's just not do that anymore. All right, we did all of that. The reason that we consider calcium and potassium goes straight back to that idea of the action potential. Action potential never goes away. I talked about it constantly yesterday, even though we were doing heart stuff and patho as well. So remember that resting membrane potential. Potassium's really, really important for setting that up. Calcium's really, really important for how the contraction occurs. In order to understand too much calcium or too low calcium, what you really need to understand is the difference between calcium inside the cell and outside the cell. These two are incorrect. Hypocalcemia should be increased heart rate and contractility. Hypercalcemia should be depressed heart and heart failure. It's taken me forever to keep these straight because they are counterintuitive for me. I think as of Monday, I finally got to the point where I understood what was going on here at the cellular level. Hyperkalemia and hypokalemia are a little bit easier and more straightforward. So potassium determines resting membrane potential. So you guys remember most permeant ion at resting is potassium? Yep, okay. So in a cardiac muscle cell, that resting membrane potential is actually -90. And then remember that threshold potential, the point at which an action potential will fire, is at a set point, usually about 15 millivolts higher than the typical resting potential. Now, potassium is a positive ion. -90 means we're in a very negative environment. If you put a whole bunch more potassium, positive, into this environment, is it going to make the environment more positive or more negative? More positive, which depolarizes that membrane. So instead of saying getting -90, if you have too much potassium in your system, you're sitting up a little bit higher. Let's say 10 millivolts higher. I don't know. I don't have exact numbers because I don't know what their potassium load is, right? And that brings us closer to threshold, which means is it easier or harder for an action potential to fire? Easier, absolutely. So in hyperkalemia, you're actually going to increase your action potentials firing. You're actually going to have more likely to have a higher heart rate, to have muscle twitching and cramping, neurons firing. Whereas hypokalemia is going to do the opposite. If you have fewer potassium ions, is that going to depolarize or hyperpolarize the membrane? Hyperpolarize the membrane. And now you're sitting further away from threshold, which means action potentials are easier or harder? Harder. And then you're going to have less activity in your muscles, including your heart muscles. Feeble heartbeat, bradycardia. And that's what I want you to focus on for that, is the cellular mechanism of it.
That's going to throw me off with the hypocalcemia.
Yeah. I'm going to go back to the calcemia. It throws me off too, which is why it's wrong, is because it threw me way off for a very long time. And I had to look into about 40 different research articles to make it make sense to me. So, 40 might be an exaggeration. Here's a cell, any given cell. And you've got all kinds of gradients acting on this cell, right? You've got pressure gradients, you've got concentration gradients, you've got electrical gradients. So one thing about electricity that you need to know is that positive doesn't want to be around other positive. Positive wants to go to negative. It's that the electrical gradient is positive to negative, and negative to positive. One's positive to negative. Calcium is very positive. Sodium is also positive. So if there's a bunch of calcium around, does sodium want to be there? Nope. Sodium wants to go somewhere else, down its electrical gradient. So in a state of hypercalcemia, where you have circulating calcium that is high, you're actually scaring away the sodium that's responsible for depolarizing the membrane during the action potential.
So hypercalcemia is like a lot of calcium making this. Okay.
Yeah, so hypercalcemia is a lot of calcium getting rid of the sodium, which would actually be responsible for depolarization, thereby making the action potential more difficult and thereby slowing things down.
Okay.
Yes.
Yeah, that was helpful.
Oh, I'm so glad. I'm so glad somebody understands that, because that took me literally the entire time I've been teaching here. Okay, so again, these are reversed. Hypercalcemia is going to decrease action potentials, whereas hypocalcemia is going to increase action potentials.
Because it's so in the hypocalcemia, is that where there's more sodium and less calcium?
Correct.
Okay.
Yeah, in hypocalcemia, there's plenty of room for sodium to be around to depolarize the membrane.
So hypo, lower calcemia, hyper, a lot more calcium.
Yes, correct. Okay. Excellent. Does everybody else get that? Awesome. I'm so glad. Many, many thanks to the one person who managed to actually explain that effectively on the internet out of many, many people trying to explain that. Okay. If your heart fails, recall that you've got two sides to your heart. You've got your pulmonary circuit and you've got your systemic circuit. If heart failure starts on one side of your heart, and typically heart failure starts on a right or left side, then that side that failed is going to not do a very good job of pushing that blood forward. Instead, that blood is going to become congested before or upstream to where that heart is failing. So by heart failure, we mean some dead or non-effective cardiomyocytes in the wall, right? So contraction can't move it forward, therefore it gets stuck back behind this part of the pump. So we're going to see this concept in patho, left versus right-sided heart failure. In right-sided heart failure, blood is going to pool in the body, and it's not going to be pushed forward towards the lungs. In left-sided heart failure, blood is going to pool in the lungs and not get pushed forward to the body. So far, so good?
That's the how people look if they have those.
So acyanotic, or being cyanotic, that can be related to that concept. Let me think about which one's more cyanotic. I want to say the left-sided heart failure is more cyanotic, but don't quote me on that till we get to patho and I have the picture in front of me for it. Yeah.
I always remember left-sided, your lungs are wet, like left and wet kind of rhyme, and then right-sided, your shoes get tight.
Nice. Yeah.
So that's how I...
Yeah, that's a big thing that you're going to see. In right-sided heart failure, you're going to see edema in the legs. You're going to see edema in the feet, so your shoes won't fit. Yep. So right for tight. I like it. And then left for wet. It's backed up in your lungs. You will have pulmonary edema. So yes, left wet. I like it. I'm just repeating it.
Yeah,
Okay.
no,
Yeah.
it's...
Chris.
So if the left side fails, is that like someone, can that cause you to cough up blood?
Not necessarily blood. It can cause you to you have coughs and crackles and wheezes is kind of the signs that I recall from that. Yeah.
Will it increase, does that cause pulmonary hypertension then? Is that where that comes from?
Some of it, yeah. Pulmonary hypertension for left-sided. Absolutely. I believe so. Let's see. Eventually, one-sided heart failure leads to both-sided heart failure, but that's where we get the idea of congestive heart failure. That heart is, that blood is pooling somewhere that it shouldn't be. And that's it. We finished. Any questions before I turn off the recorder?